Now, I will talk of global medicine. I have no conflict of interest to declare. When Francesca asked me to talk of this issue, at the moment I found the proposal rather intriguing, but after a while I felt like this child. Now, what do we mean by global pediatric oncology? Well, approximately 80% of children can be cured in high-income countries. Now, the rest of the world is extremely heterogeneous. You go from situations of countries with very low resources, like would be African countries, let's say Mali, let's say Tanzania, or you could say also Haiti in the Caribbean region, where the probability of surviving for a patient, for a child with cancer, may be less than 20% or even less. Thus, the place where the child is born is the first and most important prognostic factor for his neoplastic disease. But then in the non-high-income countries, you have an extreme variability. You have countries which are considered as lower middle-income countries. This would be countries like those of Central America. Upper-income countries, this would be countries like Argentina, like Brazil, India, China. And also within these countries, you have also a lot of variability because you have also institutions where treatment of excellence can be given. So it's extremely variable. And in fact, the cooperation with these countries may go from basic needs of training up to the institution of bone marrow transplant centers. And Monza has been involved in all this process, and right now is involved also in process of instituting transplant centers in some of these countries. Now I will tell you briefly what we have done as an example. We started in 1986 to collaborate with Nicaragua. At that time, Nicaragua was extremely poor, would be considered a very low-income country, and with a great level of illiteracy. This picture shows a child that is involved in the literacy campaign. The hospital was like this. You can observe, for example, that there are only a couple of cars on this picture, and right behind. The situation has changed a lot over the years. The situation was described at that time by the director of the hospital with this statement: when a child is diagnosed with cancer of leukemia, a little black cross is put nearby his name. We do not have the resources to give an adequate treatment. And this is the situation where we started to work. And this was a sort of twinning program between our institution of Monza, which was joined by the group of support from Bellinzona, is a medical association for Central America, and by the Institute of Milano with the Bianca Garavaglia institution, here represented by the people who are here. In 1996, we started a new initiative, which we called Monza International School Pediatric Hematology Oncology. This was to involve pediatric oncologists. Here you see a picture of that year from many countries, from Latin America, this is from South America, and from, in particular, from the area of Central America. And we were able to help them to constitute a group which is called AOPCA, which stands for Association of Hemato-Oncology of Central America, where they have been able to work together and to use protocols which are common for many different diseases. Filippo Spreafico has helped for his part too in this regard. You see a picture here. This is Professor Masera, who was the chairman of our institute. In the middle, you have Dr. Fulgencio Baez, and on my right is Dr. Pacheco, responsible for the treatment of leukemia in Managua at that time. And they are discussing how to treat these patients. Basically, the process was to look at the treatment we had and to modify, basically reduce the intensity of treatment to make it adapted for the local situation. This occurred throughout the countries of Central America, and outcomes practically showed that the situation is very different from ours. For example, induction deaths for acute lymphoblastic leukemia is over 5%. In our countries is 1% or less. The same is for a patient who died while in remission. And another aspect is the abandonment of treatment. And by this, we mean that patients begin treatment, but after induction treatment or during induction treatment or shortly thereafter, do not come back to the hospital, and thus they will eventually die. This is practically an event, and which has to be considered as such in the analysis by abandonment considered as such. Results have improved, although of course they are not like our results, but for example, you see here in Central America, approximately 50% of children can be cured with acute lymphoblastic leukemia. And if we consider those who do not abandon treatment, results are a little bit better and may reach 60%. Now, when we talk of countries with non-high income countries, the situation, as I said, may be very different. This is the data from Campinas in Brazil, where they have a very nice institution. And you see that the event-free survival and survival for acute lymphoblastic leukemia are approximately 70% and 80% respectively, which is about 10 points less than what is achieved in high-income countries. There is an important initiative which is involving the WHO. This is also has been triggered, motivated by St. Jude Children's Research Hospital, with the goal to achieve at least 60% of cure in the world for children by 2030. Now, WHO has also recommended to pay particular attention to the diseases which are frequent and highly curable, and this besides lymphoblastic leukemia are Burkitt lymphoma, Hodgkin lymphoma, retinoblastoma, Wilms tumor, and low-grade glioma. In particular, for lymphomas, I can show you that also in Central America, results for Burkitt lymphoma show that 3-year overall survival, which is basically cure for this disease, is 70%, not far from what is achieved in high-income countries. And the same for Hodgkin disease, when abandonment is considered an event, event-free survival and survival are respectively 70% and 80%, and if only patients with no abandonment of treatment are considered, event-free survival is 80% and 87%. Now, this is to say that also in non-high-income countries, probability of being cured is important, and to reiterate that children and families' expectations are exactly the same of those who are treated in high-income countries. In this plan, which I mentioned, St. Jude has designed a sort of plan where all aspects are being considered: pathology, radiology, nursing, infectious disease, pharmacology, intensive care unit, pathology. And these are considered for oncology, hemato-oncology, and surgical aspects, and considering also research program building and education, but something is missing in all these aspects. What is missing? Sport therapy. Thanks for your help, is what this child tells you.
I was thinking with Francesca and Valentino to talk about how we might implement an exercise intervention, or how we might begin from ground zero an exercise intervention in pediatric oncology and in low and middle income countries. I really thought it was a very challenging task. And this is the reason why I want to take it a little bit wider, not that much wider. But to me, the first remark is that there is plenty of evidence saying that poverty and low activity are very much connected, are strictly connected. There is a lot of evidence. And the inclusion of poverty in this general title, non-communicable diseases, want to signify how limited resources at different levels, at individual, household, community levels, and associated with personal powerlessness, constrain individual options of nutrition and of physical activity, and all the related disease. And yes, poverty restricts people's capacity to make healthy choices. But on the other end, there is also very few papers, very few evidence, for instance, about the economic burden of physical inactivity, which is very much important in poor countries, in limited settings. Just to give you an example, in this paper, there was a very nice relationship. There was a trend towards an higher prevalence of physical inactivity and either income inequality in different settings, but most of all within middle-income countries and also in high-income countries. But I mean, it looks like a paradox that in very poor people there is not this difference, but it's important to explain why, because in very poor settings, people are very active, but because they are obliged to be active, because the vast majority of physical activity was occupational, they do more than recreational. So they do very strenuous, very hard works. Maybe they walk a lot to go to a job, which is a completely different issue in terms of healthy physical activity. And another aspect is that there is much evidence that there is a gender inequality. Women are more inactive than men for many different reasons, and this is particularly true in middle-income countries. So when I talk to my colleagues about renal tumor, I don't like to say that pediatric oncology is a paradigm of success of oncology, because this is true only for high-income countries. Like Valentino said, I mean, up to 90% of children and adolescents with cancer do live in low and middle-income countries where survival is disappointing. So let's keep in mind this picture, this map. This is a paper showing the prevalence, global prevalence of insufficient physical activity all over the world, and the highest level of physical activity were among women in Latin America and the Caribbean. So I was wondering, I was impressed about overlaps. Of course, I'm aware that there are many confounding factors, but let's keep in mind that there might be a relationship between cancer mortality and a lower physical activity. Again, I am aware that there are many confounding factors. So started to bring a little bit my experience with Central America. Children from middle-income countries are affected, for instance, by obesity. When we think about malnutrition, obesity is much more important than lower body weight. And low physical activity and high screen time in Central America are regarded as two major contributors. And important to say, for instance, factors conditioning low physical activity may depend on the environment. So they have less safety, neighborhood, less green park, or maybe poor transportation. So let's think, if we have a nice in-hospital exercise program, maybe that might be an opportunity. Of course, you know very well which might be the benefits of exercise in pediatric oncology, and I was wondering why, which additional benefits might be in less, in less resources countries. And Valentino mentioned about abandonment. Abandonment of treatment is a major cause of treatment failure in poor countries. And so I was thinking that to have an in-hospital exercise programs might be an additional value to enable socialization between families, patients and the doctors or nurses, but also to implement a model of exercise interventions could be also an opportunity to promote physical activity equity and more equity between genders, and to transfer this model in other healthcare fields. when I was thinking about the barriers to implement of an exercise programs in pediatric oncology, I mean, my experience is that lack of resources might be a less important barrier than lack of knowledge, lack of confidence, lack of awareness of our colleagues about the importance, about the benefits of exercise oncology in their patients, more than a lack of resources. When I talk to my colleagues sometimes and telling them, listen, I'm going to think about how we might implement exercise programs in Central America, answer is, why are you thinking? Forget this. They even do not have money to buy medicine, which is not actually the point. I mean, my experience started 10 years ago. I don't have a picture with Valentino, who was a mentor. On your left, Professor Andrea Biondi, you met yesterday. This was 10 years ago. They have some resources. They have good resources. This is a picture from the Pediatric Oncology unit in Guatemala Hospital. It's a leading pediatric oncology center. These are some pictures from the world. These are from the intensive care unit. So they have resources. To me, the point of culture, of awareness is more important. For instance, they do not have any attitude towards central pathology review of the diagnosis, which is considered a gold standard now in high-income countries. When we were there, that person there is Gordon Vujanic, who is the chair, the reference pathologist in the Cyoprenal tumor study group, and we could arrange a sort of central pathology review session. They have portable microscopes in hotel halls, but they were not thinking that that was important. In the past couple of months, when Francesca told me about thinking of that, I just made a very simple survey to our colleagues from AOPCA, is the Central America Association of Pediatric Hematology and Oncology, just asking two simple questions. Do you have a gym in your hospital? Do you have an exercise program? And do you have a rehabilitation program? And none of them has a gym or a sport therapy program. Half of them has some rehabilitation or physical therapy programs. And of course, all of them were very much interested to know more about this from this group. And I just want to remark two answers. In Costa Rica is the only center who has a sort of recreational sport therapy, because they have a formal connection with a soccer school where they can send survivors, which is funded by the Ministry of Education. But most importantly, in El Salvador, our colleague in Salvador was very interested, because she was aware that among the National Pediatric Cancer Strategic Plan's objectives, there is to implement programs for healthy lifestyles, including diet and physical activity. And they have a connection with the university hospital, which have an Olympic field, an Olympic swimming pool. So they have facilities, they have some resources. So to conclude, I'm not maybe the right person to talk about money, but I went through this paper on Lancet with my son, who is studying emerging market at international studies. And I mean, we also need to keep in mind that about the healthcare cost of physical inactivity. In Guatemala, it's around $70 million a year. So the money that they could be saved if we let people exercise. Or in Brazil, it's around $1 billion a year. So to conclude, I think that if this group is thinks that to improve exercise in high-income countries is an important task, I think that this is even more important where physical activity is even more lacking. So I think that to me, most important is the perception, the attitude of our colleagues. If we want to start to think about that, this is very much important. And the second point is, it's also very much important to think of solution adapted on local factors, like Valentino showed very well as far as treatment. So thank you very much for listening. So this was after the General Assembly in a couple of years ago. Yes. Thank you very much. Yeah.